EHR Data is the 7th startup company that I have founded in the last 41 years. This is the culmination of a lifetime of work that started in pharmacy. Most people think about an electronic health record as being a group of EMR vendors that are in doctors' offices and in hospitals to create the electronic health record. National Health Coalition is a group of companies that started out in pharmacy rather than the EHR in doctors' offices. This gives you an idea of my background. When I got out of pharmacy school in 1971, we used a bait stamp to put a number on a handwritten prescription. Then we'd take a mechanical typewriter and type the label and attach it to the prescription bottle. We went from that to pre-numbered forms and an electric typewriter from IBM. From there, we took a big move and got a Series 1 IBM computer. A Series 1 was a mini computer, huge product. It had 9 megabytes of disk drive and 15K of memory. And they expected us to run a pharmacy on it. So pretty quickly, we figured out that $36,000 for the hardware was too much money for an independent pharmacist and moved on to the IBM PC. It was a single user, single tasking product that chains couldn't use. So Ron Austring and I got together and moved on to AT&T 3B1, which was a product that AT&T started and immediately got rid of. But that's what we installed our first trained pharmacy with, because we had a 3B1 in each store, and we collected all of the data from it at the company headquarters on another Unix system. So that background took us to creating data that is standardized with national health information. National health information created standard data, and we knew we had to get eventually to a central patient record that was standardized too. So we moved on and created EHR Data, and we'll move that on to Bitcoin. EHR Data is a subsidiary of National Health Coalition that was created to deploy and operate a utility to address the opioid crisis in the U.S. as a role of the national facilitator. We figured out a way to do this. We'll show it in a minute. And we also, for the first time, are putting the patient in control of their data rather than a doctor, a third-party payer, et cetera. So our goal is to migrate 41 years of healthcare experience to nChain, smart contracts, and Bitcoin SV, and follow Dr. Bright's lead to place the individual in total control of their health care. So rather than looking at patient data as a place to make money, which you find a lot in chain drugs, hospitals, and doctors' offices, we've chosen to use the central system as for patient safety and create a global electronic health record. Let me tell you a bit about why global. We decided to do this so that somebody that is living in London and has a prescription filled at Boots can then fly to the US and have it refilled at Wayne Reed. We're also doing a global workflow that will allow things like electronic prescriptions to share the workflow between the doctor's office and the pharmacy. Ron Austring will show you a bit about that in a few minutes. It will decrease healthcare costs quite a bit because you have a group that fills the prescription or actually writes the prescription at the doctor's office, and with data entry, and then you have to do data entry again at the pharmacy. So by decreasing the data entry or eliminating it at the pharmacy, it'll dramatically decrease the cost of filling a prescription. Now, this is a diagram of how everything works. You'll notice at the top of the diagram, the patient has the ability to authorize what healthcare professionals can actually see their data. We first created a silo of pharmacy records, and then we added clinical information to create the electronic patient record. And what you see here is a number of partners that we put together that exist today. So the parent company of EHR Data has 41 years of experience creating real-time healthcare data in the pharmacy business. And the partnerships you just saw adds data to the pharmacy data to create an electronic record. The industry people that say they're going to get into this and fix it with money include Google, Apple, and Microsoft, but they simply don't have the experience to be able to put this together. I'd like to introduce Cheryl, Dr. Cheryl Jorgenson, who is our Chief Clinical Officer.
Thank you.
Thank you. Thank you, Ron.
Thank you, Ken. Well, good morning. I am Dr. Cheryl Jorgenson, and I'm the Chief Clinical Officer for EHR Data. And everything has a purpose and a change. Epidemics and crises cause change. When we look at patients' information, their clinical data, it's siloed. It's not interoperable. And so when we look at the opioid epidemic, that's a big cause. So today, when we talk about the opioid epidemic, we're also going to look at that as a force to open the door for interoperability. So today, currently, we're looking at the countries of the United States, Canada, Australia, are one of the top consumers of opioids. They also have the highest mortality rates. Countries like Denmark are showing over 300% increase in their total consumption of opioids. And depending on the country, their drug of choice are from morphine, methadone, fentanyl is a really big one, oxycodone, oxymorphone. Those medications are being consumed in higher and higher quantities, which are causing overdose, respiratory distress in the whole world. So when we look at the opioid epidemic, it's not just one country, it is worldwide. Looking at the United States, you have to look at really geographical. So the highest consumers in the United States are West Virginia and Ohio. And you'll see a lot of news that a lot of those states are suing manufacturers for the increased consumption of the patients on opioids. So when you look at this, and I know David Washburn kind of took one of my slides, in 2017, 70,000 patients died of an overdose. The National Security Council shows us that there's a predominance that you will die of an overdose versus a car wreck, which is very scary data. So, as David was saying, every day, it is really sad data that 150 to 250 people die of an overdose in the United States. That cost a total economic burden in the United States of $78.5 billion per year. So how did we get to this current situation? There's a lot of things that are causing it, but the one big one is that patients' health care are siloed out. There's no interoperability, there's no exchange of healthcare data, so physicians prescribe not knowing that there's other physicians who are prescribing the same type of medication. When you're sick, you're having surgery, you're not realizing that maybe multiple physicians are also taking care of you and are also prescribing those medications. We also have folks that are on purposely going around and trying to get prescriptions for opioids, and that also leads to higher consumption rates. The big thing that we'd like to look at is that there's multiple data silos. There's no real-time clinical data for healthcare providers. That means we have to get out of our workflow to go into another database to try to look up in not a real-time database to see if our patients are trying to shop around or if they have multiple doctors. The big thing that we need to have in a healthcare provider's workflow is a calculation, it's a very simple one, of the morphine milligram equivalent. That tells exactly to a physician whether or not that patient has a propensity for an overdose. Very easy, there's medications that you can kind of give to them that they can have on board, just like a fire extinguisher that we have at our house to make sure that the house doesn't burn down. So it's very important that the data is delivered real time and that it's accurate and that we have tracking for these clinical services. So, a solution. It's not rocket science that for us to be able to treat a patient holistically, we need to have all of the data together, not into little bitty pieces. And we believe blockchain is the technology that will help create that interoperability. So the other things is making sure we consolidate the silos. Patient ownership, it is key. I don't know about you, but I own my healthcare data. I need to learn, and everyone needs to learn, to be consumers of our healthcare data. If we own and we have the ownership to be able to say, I want to see this physician and not a different physician. I want to change. I should have that right to give permissions out. But I need all of my data together. I don't need to go and remember that I was hospitalized 10 years ago. I went and saw 3 or 4 different physicians. I need that data together. Also, having all of that data together, you can introduce reward programs. Patients can be incentivized to have healthy habits, lose weight, exercise, having Fitbits that are going to be connected with that data that they all have together. As I said, it is a big focus that patients need to change the way that they look at their healthcare and become consumers. So, interoperability, very important. This is one thing that we are looking as a company to show a proof of concept. And what we're doing is that we are bringing together states' databases all together so that they're not a desperate, siloed out. And we're bringing in pharmacy, physicians, and also hospitals. What we're going to show is that interoperability is obtainable, utilizing blockchain and Bitcoin SV. This is going to be big for the United States because every state has their own program. So nobody talks to each other, right? We all own our own data. We never want to share it. But what comes next is operability. So we're not just pharmacy data, but it will be all healthcare data that we're going to show. Some of the data sources that will also be included are wholesalers, information so that data can be sold with permissions given and granted by patients. With that, I'm going to go ahead and introduce my colleague, Ron Austring.
Thank you, Cheryl. Can everyone hear me? Okay. So as Cheryl pointed out, the opioid proof of concept will prove the importance of a single source of data. And this is so important, right? And we could actually end this story here because what's been developed so far is all running in a traditional data center in the cloud. And that could be the end of the story, right? But there's a huge piece that's missing here, right? There's the trust of that data, the immutability of that data, right? So that's where we started thinking that we needed to go find a database that would support that. So we use all kinds of databases within our company now. We have databases that are designed for very fast access, like something like an elastic cache. And I'm calling these databases because they're data sources, right? We have transactional databases. We have analytical databases like Snowflake, right, that are used just for analytics. So as you can see, there's these different types of databases. So blockchain to us is just another database, which brings to the table, it brings trust to the situation and immutability for us. It also happens to bring a cryptocurrency with it, which is basically our electronic currency that we can do some really powerful things with. So blockchain is going to be key to deliver on a global healthcare record, or what we call a GEHR, okay? As David Washburn pointed out, nChain is going to work alongside with us, and we're going to develop a parallel POC. So we have the POC that Cheryl was talking about on one side, right? And at the same time, we're working with nChain on a separate POC that's going to prove that we can take this healthcare data and put it on a blockchain safely. And that's going to give us the immutability and the auditability that the industry so desperately needs. There is nothing right now that actually does that, okay? So this is leading edge for us. So why nChain? Well, we think they're the experts in blockchain for delivering enterprise solutions, right? So we are talking about huge volumes, so we needed a solution that would stand up to that. So that's why we initially started talking with nChain. They also brought the insights of what we could actually do on a public blockchain. And that's a story in itself. I mean, we went through our research to say, this was all new to us. And we had to figure out, do we want to use a private blockchain? Do we want to use a public blockchain, a permission blockchain? What is it, right? And what we decided after looking at all that is we wanted a public blockchain. And we wanted that so that that trust and that immutability is separate from our business. So we can't affect it, and our industry has no influence on it. If we had chosen a private blockchain, right, or a permissioned blockchain, you now have a group of people that are deciding on those permissions. That would not work in the pharmacy industry. There's too much politics, and someone would gain control in that situation. So our solution is to go public, right, a public blockchain. So what we also, with nChain, we're looking at the patented techniques such as MetaNet. We're key to achieving our vision for a global electronic health record. When I initially saw the MetaNet technology, I think it was a while back now, but I just went, wow, that is what we need. So when we started talking with nChain, that was the key focus. Also, nChain Platform Services was key to providing the technical capability to deliver on our vision. As David had pointed out, they have a solution of packages that it's just basically, it's plug and play for us, right? We just want to treat the blockchain as a data source that we can push data to, and then we can listen for data coming back, right? Because our solution is going to be a combination of things here. So if we look at the healthcare utility itself, right, it's going to be a global, it's going to support a global EHR, which Ken talked about or introduced here initially. It's a data repository based on Bitcoin SV blockchain technology. It incorporates patented EHR data and nChain technology. So we're both bringing a kind of a suite of patents to the table. As you can imagine, after being in business for 40 years in this industry, we have our own set of patents. nChain has theirs. And so that combination, I think, is going to protect, and we call it protect. It's not necessarily a way to make money, it's to protect the solution, okay? And that's what the patents will be used for. It's also, the solution is going to guarantee privacy. And we're going to do that with private keys, immutability, and encryption. So that combination, in combination with like an HD wallet, gives us a MetaNet structure that is obfuscated, and it's encrypted, and no one can basically tell, they can't relate any healthcare event to an individual person. Our solution is going to be centralized and distributed, and this will evolve as well. So right now, it's obviously a cloud platform is also somewhat distributed, right? You can set it up that way. But if you think of our solution in the United States, that's running on a data center right now. So that's our centralized bit. The decentralized or distributed side of that is going to be the Bitcoin SV blockchain. That will be worldwide, and it'll be the conduit that we use to move financial transactions around the world and also data around the world. As Ken pointed out, if you go to a Boots pharmacy here in London, and then you go to the US, the only way that's going to happen is the data flowing into a blockchain, getting listened to on our side, and we will suck up that data into the data center in the United States. So eventually we will have data centers all over the world that are listening to the blockchain and also writing to the blockchain. So they'll all become synchronized. So when we get there, we will be a totally distributed solution as well. So we also have another product that's part of this global EHR, and we call it Global Workflow Engine. And what this does is it uses Bitcoin SV blockchain to provide a single source of truth and transparency. And it uses patented nChain smart contract technology to manage the edit workflow. It utilizes Bitcoin SV's high transaction processing throughput. So what all this means is that a workflow engine is basically, and I'm going to show a slide at the very end as an example, but it's a way that manages the workflow in a pharmacy, right? And this is not only just data, it's data going back and forth from initially the prescriber, the doctor, into our center. And then there's transactions that'll go back and forth in that scenario, right? And I'll talk about that a bit later. But it's basically a workflow engine that can work globally. We also use the Bitcoin SV cryptocurrency for financial settlement. Okay, so that's going to be our lowest level of the financial settlement. we'll have the ability to move Bitcoin SV into US dollar tokens or Swiss franc tokens or British pounds or whatever, right? And that will be, I think, key for the introduction of getting everybody onboarded. And then what that does is it eliminates invoicing, accounts payable, and accounts receivable in our system right now. So in the pharmacy industry today, when a prescription is filled, it's like a Visa transaction. So the pharmacist fills it out. If it's on an insurance or even cash, it goes into a central switch, and then from there it goes to the payer that's going to pay for it. If the payer decides that they are going to pay for it, you just simply get a number back, right? That number, you don't get paid now until maybe a month from now. They'll send a check, and they'll send a sheet of paper with all the numbers and the authorization numbers. So now you need reconciliation. So you imagine a pharmacy that's trying to do just-in-time inventory, right, by having a drug on their shelf for maybe 2 days before they actually need it. And then they have this 30-day window after to get paid. It's ridiculous, right? And it's a total loss of money there. So we're going to streamline that payment system. So the other thing that we're doing is, through all of this, and Cheryl talked about this, is that we're empowering patients through the MetaNet as well. It's going to be patient-directed access with permission of data for specific services. So the patient is going to own their data. Patients, by law in the United States, own their data, but all this data is spread out on all these silos that Cheryl talked about. None of those silos talk to each other. So you can actually go to, and this is why we have the opioid crisis, you can go to a pharmacy in the United States, like say a CVS, get a prescription filled. A few days later, you get in some kind of a problem with your back or something, and you need some other medication. You go to the nearest convenient pharmacy, which may be a Walmart. Those two systems don't talk to each other. I can get my prescription filled at a Walmart, and that prescription could cause a fatal drug interaction where I die, right? And this is only caused by the fact that we don't have this central patient record, which is crazy. I'm embarrassed to stand in front of you today and say I've been working in this industry for 40 years, and that's never been a priority of the industry. That's embarrassing to me. So with the patient owning their data, they'll also be able to permission that data. And they'll be able to monetize that data, because now once you get all this data in a central place, it's extremely valuable, okay? You can just imagine. We're also going to be putting medical device data on there, like your Apple Watch, your heartbeat. Your doctor could prescribe that they want your heartbeat logged or your glucose metering logged, right? All that data is going to come up into your central patient record. Can you imagine how, like for drug research, drug companies, how valuable that is? So that money, instead of getting paid to existing people that are making the money on that now, patients don't see any of that money, is now the patient is going to be able to monetize that. And everybody will get little pieces of that, but the patient will also get rewarded as well, okay? The MetaNet also removes the barriers that have been previously created by these data silos. As you can imagine what I talked about earlier, it is the lowest, it is the protocol layer that moves this data around. This has never been possible before in a trusted manner, okay? It's the hierarchical structuring of the data, the obfuscation that I talked about earlier, the standardization of healthcare data, as Ken talked about. We have standardized how this data will actually get put onto the blockchain. And as we move into new countries, we will do the same thing that we've learned in the United States. And it's the ability, like I said, for patients to monetize their data. That MetaNet is key for us to do that. So why Bitcoin SV? Well, it's a proof-of-work public blockchain. It is the only technology that guarantees immutability of records. I think until that's proven otherwise, like proof of work, until somebody can prove something else, right, that actually has a track record, like the Bitcoin algorithms, then we'll be talking maybe something else. But right now, Bitcoin SV, the solution is it's there because of the proof of work. The incentive model enhances security of the blockchain, vital when working with healthcare data. So like I had said also earlier, like the public aspect of this chain, That is a separate business that's incentivized by its own economics. And that's key to us. And that incentivization is what is securing the blockchain. It's a global electronic healthcare record requires a single global blockchain to provide a portable EHR. I've already mentioned this. I think it's worth repeating. It is that conduit, okay, that gets the data moved throughout the world. Why Bitcoin SE, if we continue with this? It's the scalability is key in ensuring that we can handle millions of healthcare-related transactions every day. And we're going to talk about that in my last slide. Interoperability and portability of data across entities are key drivers of choosing Bitcoin SV. Data plus value is information, and MetaNet provides a way to structure and monetize that data. Archival and data storage capabilities are key to monetizing data access to patient data. So we all know with like a MetaNet solution is you need to be able to archive that data. And it's just amazing what's going on in this world now with Bitcoin SV, how it's evolving to solve those issues. So what we're talking about here is in the opioid situation, we have 400,000 prescriptions are filled every day in the United States for opioids, okay? This is going to result in 1.2 to 3.2 million BSV transactions on a daily basis. These are some of the numbers. When we evolve this, so the opioid thing is just a proof of concept. Once that proof of concept is done, we hope to get this mandated by the US government or possibly other solutions where we now see every prescription, because this really makes sense to have a central patient record. I think it's like Cheryl pointed out, it's obvious, it's not rocket science here. When we do that, there's 4.2 billion prescriptions fulfilled in the United States every year. You can imagine that's going to generate between 16 billion and 32 billion Bitcoin transactions on a yearly basis. So we're talking huge numbers there. That's why we need the scalability. This is my last slide. I know I've gone over time here, but if we look on the left-hand side of this diagram, or the right-hand side actually, the prescription starts at a prescriber or a doctor, right? If they send it in to us, because now this workflow is connected, is that we can actually look at the prescription that the doctor's prescribing. We can do several things with that. We can tell them already, like right away, if their MME, their morphine milligram equivalent, is going to go over. Because the doctor may not be aware that the patient has a prescription from their dentist, right? So we'll be able to tell that. We can also, if you have your genomics as part of your EHR, we will be able to tell the doctor that they can't metabolize this drug, or they're a slow metabolizer, or they're a fast metabolizer. So if you give them the dose you're talking about, you will actually kill them because they metabolize this drug so fast. Okay? So all of these edits are going back and forth. And these edits are little micropayments as well that happen. So when we provide a service as a utility, there's a micropayment associated with that. So once it gets into EHR data, the prescription is clean, it now gets picked up by a pharmacy. The pharmacy then, we run other edits on it. The pharmacist may have to change it to a different drug because they don't have that in stock. We then have to go back and rerun all these edits again that do the metabolization and the MME or whatever, right? So we have to do all that again. So once again, edits are going back and forth, and there's financial transactions going back and forth as well. So that's that's key for this this solution. And this is what global workflow is doing here, okay? At the end, once the prescription is filled and the patient takes delivery of it, we actually close out all those smart contracts with that money that was flowing back and forth for all those edits. And that money, if the patient is going to get paid anything for that, like a piece of it, you'll have actual money or Bitcoin SV flowing into, say, a loyalty card that we will support as a utility. But we also open it up where pharmacy chains, if you shop at a chain all the time, like if you always go to Boots here, and you have a loyalty card here, we can transfer that Bitcoin SV into their loyalty program, right? So this is a way, it's an off-ramp for Bitcoin SV, and it's a natural solution, right? So I'm just going to close with this paragraph. Within EHR data, the patient has unprecedented control of their healthcare data. When a patient undergoes a healthcare treatment or service, the data associated with that event is stored in their global electronic healthcare record. The patient decides who accesses it. Thank you very much.
Hi guys, I'm Johanna Botta from CoinGeek.com, and I'm here with the founder of PDX. So let's talk about EHR and this huge new announcement of the collaboration with nChain.
EHR is a term that is used in the United States for an electronic health record. We decided to work with nChain to get a connection between the data and Bitcoin SV through smart contract. The reason for doing that is to put the patient completely in control of their healthcare data.
Why do you believe that that is so important for the patient to have control of his data? What benefits do you foresee that happening? Not just, in terms of saving lives, because more doctors will be able to access the same information, but also incentives for patients.
Data in the United States today is looked at as an economic benefit to every hospital, every physician, every insurance payer, every pharmacy benefit manager, every chain. And when you think about these silos, every one of those groups that I just mentioned is making hundreds of millions of dollars off of the patient's data. Now, I've got a question for you. When's the last time you got paid for your data?
Never.
That's the point. And if you don't go to a pharmacy or a doctor, is there any data? There is not.
No, there isn't. I'm like, is that a trick question?
So my point is that the patient should be sharing in this revenue stream that everybody's keeping for themselves in the big corporations in the US, Europe, and other places.
Really excited about the collaboration is going to allow for interoperability of data. So disparate systems of healthcare information on patients will now be brought from siloed information into one single record of truth. And that data can then be accessed to take care of that patient, right? You can't really look at a patient and try to diagnose when you only have pieces of the information. Having it all together, that one record, is going to not only save lives, but increase patient safety.
Or how can this just be happening right now? You have all these people with the opioid crisis, for example, that may be shopping around for different drugs. I mean, it's going to save lives. We talked about that. But it's not just going to do that with people in the opioid crisis. This can be taken to other genres within the healthcare system.
We really do believe that the opioid crisis is going to really open the door to allow all healthcare data to be brought together. The opioid epidemic, it is a crisis, and there's nobody out there that is going to object to having a patient's data all together. So if a patient goes to multiple physicians, multiple pharmacies, that data will be all together to be able to look at and calculate the total morphine milligram equivalent for a patient. That kind of gives us an indicator of whether or not they have a propensity to have an overdose. But this will be the stepping stone to introduce all drugs, all clinical data together and truly interoperable.
Of course. I mean, how easy would it be to go to your doctor and when they ask you to fill out that questionnaire, oh, wait, they don't ask you because they already have it all in front of you.
And you don't have to try to remember when was the last time you were vaccinated, right?
Exactly. I was telling you, Cheryl, that I think I've gotten vaccinated for several things a couple times.
So this will not only help for patient safety, but it will decrease healthcare costs, not only globally. The redundancy of tests that are performed will no longer exist.
And how did the collaboration with nChain come? Did you just look at the blockchain and think, wow, okay, this is it. This is how we do it.
This is how we bring together all of the data and also utilizing Bitcoin SV, because we believe that the patient owns their data. And why not incentivize them with rewards on the utilization of their data, whether it's de-identified or it is in drug research. That way they can help save other patients also lives with the information that we're gathering.
Well, thank you so much, Cheryl.
When we looked at all the different blockchains that were available, right, we looked at doing it with a private blockchain. That didn't really work for us because our industry is kind of famous for a few key players taking control of the situation. So it would get very political very fast, right? So we decided if we're going to have this opportunity, we're going to do this on a public blockchain. So that is completely independent of our business. So that was the big reason why going with BSV. And when you go public, there's very few options out there. That I think only one right now is Bitcoin SV. So it came down to kind of an obvious solution.
And the security.
And the security, yes.
When it's important in healthcare.
Oh yeah, when it's the other thing we looked at is that it's based on Bitcoin technology, which has been here since 2008, right? So 12 years of history there, and it's never been hacked, right? So that was important to us. Here, it's proven technology, and the transactions per second. We needed that because in the end, when we're processing all the prescriptions in the United States, we're going to it's 4.2 billion prescriptions in the United States that get filled every year. That's going to generate 16 billion to 32 billion Bitcoin SV transactions. So when you look at those numbers, right, it's an amazing rate. We're talking 5,000 to 6,000 transactions per second, right? So it's huge, and that's why we went with Bitcoin SV.
So, Ron, why did you decide to partner with nChain?
Well, for us, it was, once again, the transactions per second were going to be huge once we got into this and started looking at it. And what we needed was an enterprise solution. And you also have the chief scientist on board is the inventor of Bitcoin, right? So it doesn't get any better than that, right? So, and also we visited, before we made any commitments with nChain, we visited the offices here in London. And what we discovered was just a huge group of people there, very smart people, and a diverse set of skill set. And it's just, to us, they're enterprise grade. That's what differentiates them, I think, from other people. We wanted something that was like a black box, right? We send the data in, and we can get data out.
Why is it important to have an enterprise-centered solution?
With an enterprise solution for us, it was like we're in an industry, right? A pharmacy industry, right? So it has to be enterprise-based. We do all of our stuff right now on a cloud platform, and that tooling is all enterprise grade. So when we're going to look for a database that's going to solve our immutability problem and our trust problem, we have to go to a solution that's also enterprise grade. And that's where Bitcoin SV comes in, and then also nChain.
Thank you so much.